part of the CME committee for the next a year or so. So today we have an exciting CME that Dr. Nandasaba will take us through. But before we get to that, kindly allow me to make a few housekeeping announcements. Number one, we need, as we start our CME schedule, we need presenters and moderators. So if and when I reach out to you, we and Evans as well and other members of the CME committee, kindly don't ignore our calls. Please pick them and start preparing in advance for presenting at the CME so we can all learn from each other. And I particularly request the young ophthalmologists to agree to be moderators. You may not be able to present a full CME, but you can moderate, okay? So I request the YOF to volunteer to become moderators. Number two is that subscription payments are due. Your subscriptions really help the OSK a lot. And kindly make your payments. It's almost end of month. Please, when your salaries and your money is coming, consider the contribution, 10,000 to both OSK and half goes to COEXA. Speaking of COEXA, both OSK and COEXA, we have an OSK conference in November in Eldoret. There'll be subsidized rates for fully paid up members, okay? So please pay up and then you get subsidized rates for the OSK conference as well as the COEXA. First early birds rate end this January on the 31st. It will be held in Zimbabwe from the 21st to the 23rd of August. So if you can, the earlier the better. And then we'll announce the next date for the next CME at the end of this CME. So let me not take up too much time. Thank you so much to the early birds for joining in early. It keeps us from being oversubscribed and being locked out by 6:30. So karibuni sana. I'll not take too much time. Dr. Sheila Marco, I've seen you've joined. Kindly karibu sana to welcome our speaker for the meeting.
Thank you so much, Dr. Wanjiko. It's good to have these young guys presenting for a change. So without much further ado, let me introduce Dr. Nandasaba. She finished her MBCHB at University of Nairobi and also did her MMed, which she finished in 2016. After which she went ahead and did an ICO, World Glaucoma Association fellowship at the University of Yamanashi, and that is in Japan, which she completed in 2022, and this was in specifically glaucoma. Well, she also loves to read, and her current read is a book known as Know Your Value by Milka Brzezinski. As you can see, she's a very serious person. So welcome, Dr. Nandasaba, and let's learn a lot from you today on the OCT. Thank you.
Good evening, everyone. Happy New Year. So we'll kick off this year's CME series by making sure our IOPs are low and very well controlled. Just give me time, I load the full screen, then we can start off. Okay, karibuni tena. So today, I want us to go through understanding the OCT when we use it in glaucoma. I hope by the end of the day, we'll be able to achieve our objectives, which are correlating eye structures with the OCT scan, to know which areas to look at in an OCT scan, and know how to assess. Oh, sorry. And then they also know how to assess a glaucoma OCT scan in order to make a diagnosis and also to make a decision on if there's progression or not.
Sorry, Dr. Nandasaba, allow me to interrupt you. Please, the ones who have joined now, please mute your microphones. Thank you.
So glaucoma, as you all know, is a progressive optic neuropathy that involves the death of retinal ganglion cells and their axons. And this results in a characteristic remodeling of the optic nerve which we refer to as a tapping. So we usually pay attention to glaucoma because it is a serious illness. It is the leading cause of irreversible blindness worldwide. And the burden in Africa is particularly huge. 4% of our population is affected. And in addition to this, we have additional challenges in terms of accessing medication getting the correct, having the support of diagnostic equipment like the visual fields and OCTs. So we have a lot of work ahead of us, but that having been said, we still need to familiarize ourselves with the different machines and equipment that we have to aid us take better care of our patients. The number of patients who have glaucoma are bound to rise as our population grows and as life expectancy increases here in Africa. So what is important is early detection and appropriate management of glaucoma. This is very crucial, and timely and effective management needs to be instituted in order to slow down or stop progression of glaucoma and preserve vision, which is the main objective. Now, for us to make a diagnosis of glaucoma, we need to piece together different information that we gather from examination, clinical examination, measuring intraocular pressures, checking central corneal thickness, then investigations including Humphrey visual fields and OCTs. Now, focusing on OCT in glaucoma, it is a non-invasive modality of imaging that takes advantage of the fact that different layers of the retina will reflect light at different frequencies, and this helps us to visualize the different layers of the retina, and it plays a very important role in detecting and monitoring structural damage in glaucoma. OCT is now becoming relatively old in terms of managing glaucoma. It was introduced in 1991 and has gone through several generations. We had the time domain machines. Currently, we're using the spectral domain machines, and slowly we are moving towards the swept source OCTs. So these are just the different technologies that they use, and the evolution involves faster scanning of the retina and also giving better images in terms of resolution. We have different OCT models, different companies that produce OCT machines, and the most common that we have in the market are the Sirius machines. This is by the Carl Zeiss Meditech company from the US. We also have the RTV 100 from the Optoview company, also based in the US in California. We have a machine from Germany made by the Heidelberg Engineering Group, that is the Spectralis. The other that we have access to in our market is Octopol. Triton is also being used in some places. This one is originally from Japan. So OCT data gathers data, and then it compares this data against normative parameters that have been done over time and input in the machine software. The information is presented in two ways, that is quantitatively in numbers and qualitatively in maps. This is just a picture showing some of the OCT presentations that we have. To our left of the screen, that is from the Carl Zeiss model machine, and the one to the left is from the Optoview machine, that is the RTV, and you see they still present the same information, but in different ways. Just to go back a bit to look at the structure of the retina in relation to glaucoma and moving on to OCT, I want us to pay attention to this innermost layer where we have the ganglion cells. As we have seen, these are the cells that get destroyed in glaucoma. We have the dendrites here that are mixed together with the amacrine cells. This is one layer that we need to remember. Then we have the ganglion cell bodies, which now give off axons. This inner layer of the dendrites and the amacrine cells is what we refer to as the inner plexiform layer. And then we have the ganglion cell bodies that now have and then now eventually we have the RNFA layer from the axons, all right? Now, moving on, when we do a scan, this is the inner plexiform layer, the one here in between the yellow part. And then we have the ganglion cell layer that is formed by the retinal ganglion cell bodies. And then we have the axons that are given off from the retinal ganglion cells, and they move on to form the peripapillary retinal nerve fiber layer, and then they dip into the optic nerve. Up here is what we refer to as the optic nerve head. This is just another image showing the same. So when we are assessing a glaucoma OCT, there are three main areas that are assessed, that are scanned. The first one is the peripapillary retinal nerve fiber layer, this being our optic nerve, and this is the optic nerve head, this area right here. Then we have the macula, that is also scanned, and then eventually we also have the optic nerve head itself is scanned, and all this data is put together for us to interpret, see if there's any damage, and then we make a decision on if there's a glaucoma, and if there's any progression once we have made a diagnosis of glaucoma.
Ilikuwa hiyo wanafuata speed points kwa tuna 20 points.
There is a bit of background noise. We request we all mute our mics.
We got a 60.
Okay, so carry on from there. So this is now an OCT scan. I just want to highlight the areas that we have alluded to. This is our optic disc, and this is the peripapillary region that is scanned. So this is the optic nerve head and retinal nerve fiber layer analysis scan. And this here is the ganglion cell layer analysis. This is a scan by the CalZest machine. So the first part that we'll discuss this is the peripapillary retinal nerve fiber layer and why it is important in OCT scan. So this represents the retinal nerve fiber layer represents the ganglion cell axons. The peripapillary retinal nerve fiber layer represents the retinal ganglion cell axons just before they enter the optic nerve head. Then in glaucoma, there's destruction of the retinal nerve fiber layer with the death of the axons, which results in thinning of this retinal nerve fiber layer. So in glaucoma, we pay a lot of attention to this because it is what makes one of the hallmarks in terms of defining what glaucoma is, as per the consensus that was reached in the World Glaucoma Association, the 10th meeting, that defined part of glaucoma as thinning of the retinal nerve fiber layer. Changes here are easily detectable and reproducible with the OCT scans. So if you notice any thinning here, the retinal nerve fiber layer, most likely you could be having, the patient could be having glaucoma. It is accurate in its diagnosis. The average retinal nerve fiber layer thickness is around 104 with a range of plus or minus 10.71. When we are following up patients with glaucoma and would have scanned them, if there's an inter-eye difference of more than 9 micrometers, we should start getting suspicious of glaucoma, and we'll see some of the cases as we go along. So this is just a picture showing the different parameters of what we look at the retinal nerve fiber layer. So here we have the retinal nerve fiber layer thickness map, and it presents data in terms of color. Here it is important to note that yellow is actually normal, and there's a scale here at the side that can help you, that can guide you to know that anything presented in yellow is actually okay. If there's glaucoma and there's damage setting in at the peripapillary retinal nerve fiber layer, then it changes the shade to green and eventually to blue. Then here we have the retinal nerve fiber layer deviation map, topography map. And basically what happens here, it compares the data gathered from the patient's eye after scanning and then overlays it with normative data. If there's a deviation in the thinning setting in at that point, then it will now detect and highlight, okay? So you can see in this picture here, there's some thinning setting in, especially inferiorly and superiorly in the right eye, and in the left eye, there's a bit of changes setting in inferiorly. And then down here, we have the retinal nerve fiber layer T-SNET graph. We also have the same information presented in quadrant map and also in clock hours map. In this example, the normative data is plotted, and anything that is falls within grid is considered normal, what is within yellow is considered abnormal, and what reaches all the way to red, where it definitely is abnormal. So this is another scan. This is now from the Optopol machine. You can see the name down here, and just we'll go through it and see what we can pick up in terms of retinal nerve fiber layer. So it belongs to a patient that we saw in Kenyatta. So when we look at the average numbers in terms of the retinal nerve fiber layer thickness, the right eye is at 121, the left eye is at 99. This is one of the, as we had discussed, one of the important numbers that we look at when we're interpreting the glaucoma OCT. Now, when you look at the nerve fiber layer thickness maps, you'll see it started dipping more towards the green, and this should alert us towards the presence of damage that is coming in. When you look at the nerve fiber layer significance, it also shows that there's now some red, which shows the damage coming in where the yellow star is. Now, when you correlate the retinal nerve fiber layer graphs, for the right eye, it's looking normal, but for the left eye, there's a bit of an area that is dipping towards the borderline and green area. And if you note, this is superiorly and this is inferiorly. And then, as we had discussed earlier, the inter-eye difference will give us a clue. So in this case, the difference between the right eye and the left eye in average numbers is more than 9. And then when you look at the maps, it's a bit of thinning superiorly and inferiorly, and at the retinal nerve fiber layer graph. And then when you look at the numbers on the optic nerve head parameters, you can see there's a difference in the CDRs. This is another scan for a different patient, and basically presenting the same information. So we have the average numbers here, 98 and 87, and you need to be careful that here, like in the right eye, the average seems to be within normal. But now when you correlate it now with the retinal nerve fiber layer thickness graph, you notice that inferiorly there's thinning setting in. When we look at the peripapillary topography maps, there's also thinning inferiorly. Also in the quadrant map and in the clock hour map, it is giving the same information and similar to the left eye. In this case, the left eye is a bit worse. The thinning is more. On average, it's flagging it off as yellow borderline. But when you look also at the graph, we are seeing the thinning superiorly and also inferiorly. And at the in the topography maps for the peripapillary retinal nerve fiber layer, we can also see this thinning setting in. So when you put all this together, you pretty much start seeing that this patient actually has glaucoma with the left eye being worse off. So when you're interpreting the retinal nerve fiber layer, you need to be aware of artifacts that can give changes in the OCT thickness and make you misinterpret. So if there's any corneal haze, if there are cataracts, or if there are vitreous debris, it will make the retinal nerve fiber layer appear thinner than it actually is. For you to escape this, you need to make sure that you have that the scan is of good quality and to check the signal strength. For the Carl Zeiss machine, a good scan should be more than 6 in terms of the signal strength index, and the RT-view, it needs to be more than 30. You also need to check for the model that you have. Usually manufacturers provide that information, and then you're able to tell the quality of the scan that you have. Artifacts that make the retinal nerve fiber layer look thicker include the myelination of the retinal nerve fiber layer, any epiretinal membranes, and swelling of the optic nerve head papillary area. Now we move on to the second part that we had discussed that is important when we're assessing the OCT in glaucoma. And the macula has 3 important layers that we pay attention to. That is the macular retinal nerve fiber layer, consisting of the ganglion cell axons. Then we have the ganglion cell layer, which is made up of the retinal ganglion cell bodies, right here, as you can see in the diagram. And then we have the inner pletiform layer, made up of the retinal ganglion cell layer, dendrites, also depicted in the picture that we have. below, and this is a scan that we had seen earlier.
Huyu jamaa
Now,
anafunza
we
anasema
scan
about
the
glaucoma.
macula in glaucoma because it actually contains around 50% of the retinal ganglion cell layer, and with the death of the retinal ganglion cells, thinning starts setting in, which can occur quite early in glaucoma, and this is useful in detecting glaucoma quite early. Then it has a similar diagnostic capability as the retinal nerve fiber layer, and reference thickness is usually around 82.1 micrometers, with a range plus or minus 6.2 micrometers. So different machines will scan the macula differently. The ganglion, the serous machine from Galzais will check the inner two layers, that is the ganglion cell layer and the inner plexiform layer. The RTV will measure the three and give you the ganglion cell, what we refer to as the retinal ganglion cell complex. So these images are just showing the same. Here, this is to our left is the Carl Zeiss machine, and you can see it has given a ganglion cell analysis for, and it records the average ganglion cell plus inner plexiform layer thickness, both the average and minimum. So I'll just take a few minutes to go through this image to help us understand. So when you're interpreting this, you also need to check that the signal strength is adequate. Then I'd like to bring our attention to the thickness map that also shows us if there's any damage that is setting in, with red being normal, and as you go down towards yellow and blue, it becomes abnormal. For the right eye in this patient, you can see in the inferior temporal quadrant, it's looking bluish. And then for the deviation map, where we check the difference between normative data and what the patient actually has, it flags up the thinning in at the patient's macula, both in both eyes, with the right eye being more severe. So this is sorry, to my right is a ganglion cell macular OCT from the optical machine, and the optical machine measures both the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer, which is the ganglion cell complex. It is similar to the RTView machine that also gives a ganglion cell parameters, and it will give you the total numbers of the thickness of the macula, and also gives a focal assessment and a global assessment. Now, how do we use this, the macular scan in interpreting the findings that we have in our patients? So as I had mentioned earlier, changes here can be detected quite early, and it's useful in detecting glaucoma when it's at an early stage. Sometimes you have damage occurring in the eye, and structurally there's damage setting in, but functionally when you do the visual field scans, you see that they're normal. That is what we refer to as preperimetric glaucoma. So the OCT of the macula is useful in picking this up. If there's a difference of more than 5 micrometers between the superior half of the macula and the inferior half, then we become suspicious of glaucoma. It is important to note that the inferior part of the macular area is quite vulnerable, and a lot of times changes would start at the inferior aspect, though not always. Then the scan of the macula is also useful in patients who have peripapillary atrophy and those who have myopia. And it's also important in monitoring progression in glaucoma. We shall see earlier where it comes in. So also there are artifacts that can mislead you when you're reading the OCT macular scans. So if the scan has been decentered and not properly positioned, some areas may appear thicker or thinner than they should be. If the patient has cystoid macular edema or degenerations occurring at the macula or epiretinal membranes, that will also change your numbers. So that is why it's important when you're assessing a patient with glaucoma, you put in different information that you have gathered from different areas together for you to make a diagnosis. In this case, the clinical examination, the OCT that we're discussing, and the visual fields. Now, the other parameter that we look at in the OCT scans are the optic nerve head, which will give you information on the disc area, rim area, cap disc ratio, cap volume, and retinal nerve fiber layer thickness. So we'll go back to the patient that we had discussed earlier, just to remind us of the thinning that was starting to set in inferiorly, and we can pick that up in the topography maps, in the clock hour map, quadrant map, the retinal nerve fiber layer graph, and also the average numbers. So when you now look at the optic nerve head parameters, you actually notice that the CDRs have gone up. In this case, the right eye is at 0.81, and the left eye, which is more affected, is at 0.86. Then you can also have information in terms of the disc area, which can help you now identify patients who have small discs, who may have glaucoma, but the CDR may look normal, or patients who have large discs, who may have abnormal looking CDR that are enlarged, but they're actually okay. So when it comes to monitoring progression, different machines will have different parameters in terms of picking up what is normal and what is not. What we need to remember is as you grow older, the retinal nerve fiber layer undergoes attrition, and this attrition is at a natural rate of around minus 0.48 micrometers per year. But if a patient has glaucoma, this attrition will be much faster. Then when we are monitoring the progression, there are two things that we look at: trend-based progression and event-based progression. So trend-based progression just covers the baseline scan that you did when you started seeing the patient. And then if the retinal nerve fiber layer thins to a point where it's flagged off as progression, then that is mapped out. The other way we monitor progression is it just records and stores the different scans that we do over time. And eventually, after more than 4 scans on the same machine, they're able to draw a map that shows how the patient is progressing. So for the curve-sized machine, a drop of more than 0.98 micrometers per year will be flagged off. And then in the event-based progression, a loss of more than 5 micrometers on the average retinal nerve fiber layer per year, or more than 7 micrometers in the sectorial maps, especially if it's inferiorly and superiorly, then it would also be flagged off as progression. The color-sized machine presents both. Other machines can choose either of them to present. So for us to understand this better, we have a scan here that I'll take us through. So you can see it's headed the guided progression analysis. This is by the color-sized machine. This is for the left eye of the patient. So when you scan a patient, the first scan and the second scan are considered baseline 1 and baseline 2 scans. For this patient, they had a scan done in 2012 and in 2013. Then average thickness in 2012 was 80, in 2013 was 78 micrometers, and this is now the peripapillary retinal nerve fiber layer thickness map, and you can see it's towards red and yellow, which is considered normal. Now, some years down the line, this is now scans done in 2018. You can see now the average thickness has gone down to 69, and then the second scan in the same year, it has gone down to 68. When you look at the average thickness map, peripapillary retinal nerve fiber layer thickness map, now the color is changing a bit more towards the blue. Yeah, and like what it was like before. So this allows us that the thickness is going down. When you look at the deviation maps, you can see that now it's showing in red, and there's a color code here that helps us interpret down here. So if it's in yellow, there's a possible loss of retinal nerve fiber layer over that period in time, which points to progression. And then in red, there's likely loss, which means there's an actual progression that has taken place, which is the fact for this patient. We also, now this year we have a graph. This is now the event-based also, that is now showing us how the thickness is going down. For the average retinal nerve fiber layer, when you look at the rate of change for this patient, is at minus 1.96 micrometers per year. This is more than the 0.98 that we had discussed. And then for the superior retinal nerve fiber layer and the inferior retinal nerve fiber layer, we are also given the numbers. Then the last graph on the left bottom side of the scan, we can see superiorly and inferiorly for this patient between the first scan, the baseline 1 and 2, and the current scan that is down here in blue. We can see there's an actual difference, and this is an event-based. It has just compared the first scan that we did and the current one, and it has mapped out progression. So most machines have these maps, and they can be printed out for you. So this is one of the reasons why it is important when you're scanning a patient, you don't use different machines to follow up this patient. One, because the different machines use different algorithms that are not interchangeable. And two, if you need to follow up this patient and tell you this progression, then you need to have it done consistently on the same machine. As you follow up patients, there's a point beyond which OCT is no longer useful in monitoring progression. This is in advanced disease. So this is a scan for a patient who has glaucoma, and this is the optic nerve head and retinal nerve fiber layer analysis scan. And you can see the average retinal nerve fiber layer is quite low at 58 and 39, which is classified as severe. The whole retinal nerve fiber layer thickness map is in blue. It's also quite severe thinning. And then when you look at the retinal nerve fiber layer T-SNP map, you can see this thinning that is now all the way to the red part. If you look at the, if you look at the quadrant maps, then you can also see they are almost all becoming red. So at this point, if you keep on scanning this patient, you will no longer be able to tell if there's progression or not. What happens, the retinal nerve fiber layer thins, but remember there are also other structures within that retinal nerve fiber layer. There are blood vessels, the microglia, and much as the OCT stops detecting the progression, it doesn't mean progression has stopped. So we need to find another way of monitoring that progression. And when it comes to OCT, this is where the macula comes in. If a patient has advanced glaucoma with retinal nerve fiber layer thinning and the retinal nerve fiber layer is less than 55 micrometers, then the macular OCT can be useful in terms of following up the patient. And in this, you correlate together with the Humphrey visual fields, the 10-2, which we also use in patients with advanced disease. Then also the macula comes in handy when we are following up patients who have myopia. Remember, the peripapillary area is not can be abnormal. So one of the most useful areas to look at in the scan is using the macular scans. So a progression in the macular OCT of more than 4 micrometers per year is suggestive of progression. So for this patient who had a thinning of around 58 micrometers, you can tell now this is too advanced. OCTs are not going to help. And now the macula comes in handy in terms of following up this patient. But remember, when it gets to around 45, the ganglion cell complex, when it comes to around 45, then the macula stops being, the macular OCT stops being useful in terms of following up the patients. So there's an interesting case that we have for the patient. And I had a case here in Kenyatta of a 15-year-old patient. The father had glaucoma, so there was a positive family history. Then on measuring the IOPs, the right eye IOP was 26, the left eye was at 24. Central corneal thickness, however, was thick at 543 and 553 micrometers for the cornea. And then the CDRs were 0.7 in both eyes. So we're wondering, how do we approach this patient? So we moved on to investigate, and one of the investigations we did was an OCT scan. So on average, the retinal nerve fiber layer thickness was good at 130 in the right eye and 124 in the left eye. And then from the nerve fiber layer topography maps also looked to be within normal. The quadrant maps and the clock hour maps were also looking okay. And the retinal nerve fiber layer graphs, all of them were also looking normal. The assessment of the macular OCT also showed numbers that were within normal. And when we did the visual field scans, there was also no visual field abnormalities detected. So basically, the patient almost looks like they have a physiological capping with thick cornea that would explain the high pressure. But remember, this is a patient who has a positive family history, and it brings us to one of the things that we need to be aware about, what we refer to as the green disease. So green disease basically is if a patient has a glaucoma setting in and the thinning of the retinal nerve fiber layer, but is still within the normal range. So if I just look at this patient first and decide this patient looks okay, probably I might be missing out on green disease. So I need to follow up this patient and see, are these numbers going down or are they remaining stable, so that you don't miss out on making a timely diagnosis. The opposite is true for what we refer to as the red disease. Like for example, in patients with the myopia, whose fundus is slightly different from the normal population, and you may have areas where the retinal nerve fiber layer is in the red, and it might make you think that the patient has glaucoma. But if you follow them up and you monitor progression, you notice that there's no progression that is ongoing. So in summary, the OCT is useful in glaucoma in that it helps us to assess the structure of the eye. And in this case, we pay attention to the retinal ganglion cells, the retinal nerve fiber layer, and the optic nerve head. The three important areas that we pay attention to is the peripapillary retinal nerve fiber layer, which is one of the most important areas in terms of making diagnosis. We also look at the macula and the optic nerve head. Then remember, data between different models is not interchangeable because of the different algorithms that they use to scan the patient, and also how they map out, they divide the OCT quadrant and clock hour scans. And then it is best utilized by correlating with other parameters, that is clinical examination and visual fields. So that brings me to the end of the presentation. My references are from these sources. Asanteni sana.
Thank you so much, Dr. Nandasaba. I'll just look at the questions on the chat box. So if anyone has a question, just put them up on the chat box. So we have a question here from Dr. Sitati. She's asking if the RNFL values are normal, but the graph shows some thinning, is that a reason to start treatment or follow up? So I'm guessing she's asking if the total, what you were talking about just now, the green disease. So the RNFL looks normal, but you see some thinning in some of the quadrants on the graph. Do you start treatment or do you follow up? Dr. Nandasaba, did you hear the question?
Sorry, I was muted. I was speaking and I was muted. Sorry. So I was saying, if there's thinning that is that you have confirmed there's progression and there's thinning in the retinal nerve fiber layer, in as much as it's within the normal range of values and is falling in the green area of the map, you definitely start treatment.
Okay, and I think you had also alluded to green disease, whereby one section one area can just dip into the abnormal or into the thin part, but the total is still green. So you have to always keep this in mind, and everything has to be correlated with your clinical findings. Okay, so we have another question from Dr. Gokale. Any tips on interpretation of OCT in a patient with a tilted disc?
Okay, for patients with the tilted disc, the peripapillary retinal nerve fiber layer data would be a bit skewed. And for that reason, now we prefer to use the macular map, because the macular area tends to be quite consistent in the population, even with persons who have a tilted disc, like patients with high myopia. So if you have patients with such a disc, then you can use the macular OCT scans to follow up the patient, and always keeping in mind the correlation with the other parameters, that is the clinical examination and visual fields. But in this case, the macular scans would be best.
All right, so we have another question. How does quality index affect the OCT interpretation?
So when you have a poor signal strength, like for example, we discussed in terms of there's a cataract or there's a vitreous debris, it might it lowers the signal strength of the scan. And then this also introduces the artifacts that we had discussed in terms of making some areas of the scans look thinner than they actually are. So you may end up making a diagnosis of glaucoma, yet the patient may not be actually having glaucoma, or may interpret that as a patient having progression, yet they do not have. So for us to escape that, it's always good to make sure that the scans have a good signal strength. And the other thing that you need to put in mind is when you're reading, it's good to check the intertest variability. You could have had a scan that was good, then you have a scan that the signal strength is not so good, and then it shows thinning, and you actually make a call that there's progression, and you change management when it actually wasn't there. So it's good to always keep that in mind. I don't know, probably also Dr. Marco or Prof. Kiage can also give their input on that.
So I agree with you totally. I've had some patients referred to me who are said to have progressed, but you'll find that either the subsequent quality of scans was not as clear or as good as the first scan, or the patient tilted their head or their eyes. And once there's a tilt, then that means that the OCT is going to be different from the original one, because the position is all different. And what can come out of the progression may just be interpreted as a tilt of the patient's head or the patient's eye. But remember, all these things you have to correlate with your findings, or your clinical findings, your optic nerve head diagrams, or look at, is your cupped disc ratio increasing? Is your visual fields worsening? How are intraocular pressures? Because it's unlikely that recently I had a patient who was sent urgently for progression, with progression on OCT, but their pressures had been 10. So on a closer look, the subsequent OCTs, the patient had tilted their head and the signal strength was off. So we have to correlate all these things to our clinical findings. Also, it's important to note the disc size, because a lot of patients with physiological cupping, maybe a patient has a CDR of 0.8 or 0.7, and you find they have a really large disc. On OCT, their disc size is more than 3 millimeters cubed. And you'll find millimeter square. And you'll find that these patients are started on treatment. A patient has huge discs on OCT, even 4 millimeter square. And they'll be started on treatment, and yet the OCT clearly shows that they have large cupped disc ratio because they have a large disc. So these are things you need to look out for. There's somebody I think Dr. Oscar has said he's talking for those who have been allowed in late. He's requesting, can we use a different virtual platform for the next talk? So I think this is for the CME organizers. 100 maximum is too outdated because we have very many. Alafu, the first Kedo, okay, that's Kedo 5 slides would be nice to hear. So, so Dr. Nandasaba, over to you.
Okay. I'm not sure, should I, within the first 5, just probably quickly run through. I may not discuss it in the same detail as the first time, but basically pardon?
Because of time, there are recordings that are available. All our CMEs are available, but yes, we have had about that limit of 100, and it shall be discussed, but all CMEs are recorded and all people can request for recordings to view at their own time.
Okay. Thank you, Shiko.
All right, I think there are no more questions on the chat. I'll hand over the baton back to Dr. Wanjiko. Thank you.
Thank you so much, ladies. That was an amazing first CME of 2024. Once again, allow me to go through our housekeeping issues that one, if we come to you requesting to give us CME, please do so. And our CMEs are not only for specialists. We want to do beginner, intermediate, and advanced CME levels so that everyone gains something from the CMEs. Kindly indulge us. Number 2 is that I would like for us to do moderation to be done by the young ophthalmologists. Whatever subspecialty you are interested in, just reach out to us and tell us you'd want to moderate. How else will you get to know the people who are in your area of interest? Can you reach out and don't shy off from volunteering and also from accepting an invitation when asked to do so. Number 2 is that we have an OSK conference in November in Eldoret. Subsidized rates for paid up members. On that note, kindly pay up your subscription payments. The details are on the OSK both website and also on the OSK notice board, what's that called, profile picture. You can get all the details to pay. End of month is coming up. Before you spend all your money, before mid-month, kindly pay up your subscription. It's really helpful. COEXA also this year will be meeting in Zimbabwe from the 21st to the 23rd of January. First early birds rate and end of this year, that's 31st of January. So you have a few days to pay up if you're paying out of pocket. So kindly do so if you are paying out of pocket. And then anyone who requests for recording of any of our CMEs, all of them are recorded. You can request for recording from the OSK membership. Contact Evans and he will oblige, okay? We want this to be a learning platform, so don't shy off from doing so. Then our next meeting will be on 2nd of February. Will be Professor Masharia, ENT specialist and also chairman of the Equity Holdings Group, will be giving us a talk on retirement. Retirement doesn't start from old age. I'm turning 40 this year. We should start planning for retirement from the time we start working. So kindly plan to attend, whether virtually or physically. If you can attend physically, please give feedback to Evans in advance, and would love to have you for that. For now, we have sponsors for this event. Don't turn off, give us about 5 to 10 minutes to tell you what this is about. Let me hand over to Evans for the next session.
Okay, thank you, Doc. Before I welcome the sponsors, Alagan, Abbe, first I would like to apologize for those who joined late. I had lost control of the meeting, but I've regained. Thanks for the feedback. I think that will come up for discussion next week so that we expand, even if we maintain Zoom, we expand it to accommodate a larger audience. So over to you, John, Jason, Anthony, or Pauline. I've seen Rob has joined. Thanks.
Good evening, doctors. Thank you for giving me this opportunity to be joining you today. My name is Ruba El Basha. I am a pharmacist. I'm in charge of medical affairs for PHA, the official representative of AbbVie Allergan in region Africa, including Kenya. So I'm going to off my camera just not to slow down the connection. And as you can see, today we are going to talk about intraocular pressure under bimatoprost and the impact of bimatoprost on decreasing the intraocular pressure. So we'll start with the pharmacology. So bimatoprost is a synthetic prostamide. Prostamides are quite different than prostaglandin analogs because they have some similarities, but the receptors to prostamides are different than the receptors of prostaglandin analogs, which make bimatoprost a molecule that has some similarities with latanoprost and travoprost, but that has also some differences the pharmacology and the mechanism of action and in the clinical effect. So bimatoprost appears to bind to a new receptor that is distinct from the prostanoid FP receptor that is usually recognized by the prostaglandins and their analogs. It is an ocular hypotensive, and it is structurally related to prostamide that does not act through any known prostaglandin receptors. It mimics the effects of prostamides, and the prostamide receptor, however, has not yet been structurally identified. And bimatoprost reduces the intraocular pressure in humans by, one, increasing the outflow of the aqueous humor through the trabecular meshwork, and also by increasing the outflow through the other pathway that is the uveoscleral outflow. And the effect of reduction in the intraocular pressure starts 4 hours after the instillation of bimatoprost, and the maximum effect, the peak effect, is reached between 8 and 12 hours after instillation. But however, the effect lasts for 24 hours. That's why bimatoprost is given once daily. There is no clinically relevant effects on the heart rate and the blood pressure that have been observed in clinical trials. There is limited experience of bimatoprost in patients with open-angle glaucoma with pseudo-exfoliated and pigmentary glaucoma and chronic angle closure glaucoma with patient iridotomy, and no recommendation can be made based on any clinical trial. So as you can see, the trabecular and the uveoscleral pathways that are increased under the effect of bimatoprost. Now, the clinical data started to be published for bimatoprost dosed 0.03%, because this was the first dosage that was marketed. And as you can see in this meta-analysis, when compared with latanoprost and travoprost, bimatoprost 0.03% was associated with greater overall reductions from baseline in mean intraocular pressure. Every result that is on the right of the dark line favors bimatoprost, and this meta-analysis shows that we have, as bimatoprost, an advantage in decreasing the intraocular pressure versus both latanoprost and travoprost. You have the references. So the full publications can be found and read just for you to have an access to all the details. But also, although bimatoprost was associated with a significantly greater incidence of conjunctival hyperemia in this meta-analysis, so the incidence was within the upper limits that are seen with travoprost. So if you look at this table that compares the incidence of ocular hyperemia as a side effect, you notice that it is a side effect that is common to bimatoprost, latanoprost, or travoprost. Okay, the claim is that it is more frequent with bimatoprost, but if you look at the numbers, it is between 48 and 51%, while for travoprost, it is between 42 and 53%. And compared to latanoprost, so I mean the upper limit is 36% for latanoprost of the cases having ocular hyperemia, while it is 51% for patients taking bimatoprost. This is mainly the reason behind the development of a lower dose of bimatoprost, that is the bimatoprost 0.01%, and we'll see in the next slides the rationale behind the bimatoprost 0.01%. Now, this is another meta-analysis that compares the bimatoprost 0.03% ranking for relative change in trough and peak IOP versus timolol. So this is a ranking of different IOP reducing molecules compared to timolol. So the comparative molecule is the timolol. And if you look at the bimatoprost versus timolol, so we notice that it has a better efficacy in reducing the baseline IOP. So here we're talking about -28. With timolol, we have -26. The ranking is number 1. So bimatoprost was ranked number 1 product in the reduction of the baseline intraocular pressure when compared to all these molecules, including travoprost, latanoprost, and it was ranked first in efficacy, whether it is for trough IOP or whether it is for the peak intraocular pressure. Let's talk about the bimatoprost 0.01%. So the incidence of hyperemia was significantly high with the 0.03%, and it was proven that it is directly related to the concentration of bimatoprost in the eye drop. In bimatoprost 0.01%, we reduced the concentration of bimatoprost, but we had to increase the amount of benzalkonium chloride because the benzalkonium chloride increases the bioavailability of bimatoprost, so it can compensate the eye for the effect of the reduction of bimatoprost. And the increase of benzalkonium chloride concentration has been aligned with that of the latanoprost brands that was on the market at that time of developing bimatoprost 0.01%. So that concentration was already available in another product, and it was somehow tolerated. The preservative benzalkonium chloride is increased, I said, to increase the ocular permeability and to allow greater absorption of bimatoprost to the cornea of the eye. So these factors, they allowed the development of a newer formulation, which is the bimatoprost 0.01%, that has shown to be comparable in terms of efficacy to the previous dose of bimatoprost 0.03%, but with a way improved tolerability profile in terms of ocular hyperemia. So we look at this slide and we notice that bimatoprost 0.01% provided equivalent efficacy to the previous dose of 0.03% over a period of 12 months. So it was non-inferior to the previous higher dose, and overall mean IOP change from baseline at all time points. This is the ANCOVA study, and you can follow the reference to have the full details of the study. And if you look here, when they took the mean IOP at week 2, week 6 of treatment up to month 12, so after 1 year, at all time points where they measured the mean IOP of the two population of patients taking either bimatoprost 0.01 or 0.03, they noticed that they were equally effective in reaching a lower mean diurnal intraocular pressure. It was associated with a milder hyperemia profile than the previous dose of 0.03%. So here we have the percentage of patients with moderate to severe increase in macroscopic conjunctival hyperemia at any time in the study. And we notice that we have 65% fewer cases of ocular hyperemia when patients were on bimatoprost 0.01%. Okay, and if we split the patients based on their previous treatment history, you have patients who were on beta blockers or on latanoprost or on travoprost or on tafluprost. All these patients, and I'm putting my arrow on the latanoprost, travoprost, and tafluprost, when they switched to bimatoprost 0.01%, they had a further decrease in their intraocular pressure. So we had, for example, for the latanoprost population, whether it is in the left eye or the right eye, those who were previously on latanoprost, when they switched on bimatoprost, they had a decrease by around 14 to 15% in their intraocular pressure when they were on latanoprost. The same is for travoprost, the same is for tafluprost, and for the other molecules. This slide that it emphasizes further on the idea that bimatoprost 0.01% is more tolerated in patients who switched from prior IOP lowering therapies. So after 12 weeks, we assessed the incidence of ocular hyperemia in this population of patients who had a previous treatment history. And hyperemia was graded as none to mild for 94.1% of the patients. If we see the score 0, it means that these patients did not experience any hyperemia. the 0.5, and then the 1. So most of the patients, they scored mild ocular hyperemia or non-ocular hyperemia when switching to the bimatoprost 0.01% after 3 months of treatment. Another also study that shows that patients who switch to bimatoprost 0.01%, whether they were previously on latanoprost, travoprost, or a beta blocker or carbonic anhydrase inhibitors, they all have experienced a further reduction in the mean intraocular pressure in both of their eyes. So if we want to conclude our presentation, we can say that bimatoprost that is licensed for the reduction of elevated intraocular pressure in chronic open-angle glaucoma or ocular hypertension in adults as monotherapy or as an adjunct to beta blockers. Then bimatoprost, prostamide, it reduces the IOP by increasing the aqueous outflow in both trabecular meshwork and uveoscleral roots. The bimatoprost 0.03% has demonstrated a greater overall ability to lower the intraocular pressure than timolol. And we have more patients achieving a range of target IOPs with bimatoprost and timolol. And conjunctival hyperemia and eyelash growth are the most common adverse events, but the 0.01% dose provides equivalent efficacy to the higher dose with a better tolerability in terms of ocular hyperemia. So that was all for me today. I hope I was right on time, and I hope that I was able to transfer to you the information about bimatoprost 0.03 and 0.01%. So, and now I leave the floor for questions before I close the call. Any questions? Anthony, Mary? Pauline, can should I continue or it's fine?
I've seen a question in the chat about how you'd compare it to uniproston.
Well, so far I have no, I've never get the chance to see any comparative study with uniproston. However, I will take note of it and I will ask the medical affairs department in AbbVie for any available comparative data.
Why does Gunford, this is from Dr. Marco, our one of our glaucoma specialists in the country, and she's asking how come Lumigan comes at 0.01% and yet Gunford uses 0.03%. And our concern is about the concentration and the efficacy of the two.
Okay. The good thing about Genford is it is a combination of two molecules. So in Genford, you have the bimatoprost 0.03% and you have the timolol. And the addition of timolol has a counter effect on the occurrence of ocular hyperemia. So because timolol, it reduces the ocular hyperemia by let's say not letting any space open for any foreign proteins or foreign bodies to invade the eye. So that's why the addition of timolol to bimatoprost have demonstrated that it reduces the occurrence of ocular hyperemia. And our concern with the bimatoprost 0.03% was mainly the ocular hyperemia. Now, in Ganford, we don't have this issue, and there is no need to reduce the dose of bimatoprost and to increase the dose of benzalkonium chloride to compensate this reduction in the dose of bimatoprost.
Thank you very much for your talk, very informative on a molecule that we use quite often and quite frequently, which is our first line when we encounter glaucoma. On that note, allow me kindly to close this. Thank you so much, members, for hanging in there all this time. Dr. Jyoti is saying that she has still seen hyperemia with Ganford. I've also seen the same and have had to switch. Do you want to comment on this before we close our meeting?
Okay, well, is it as frequent as it was with 0.03% when you say you still have hyperemia with Ganford? It is. I mean, it is one of the potential side effects, but it is not as frequent as Lumigan 0.03%. And another question, why does Ganford not have 0.01%? If we want to reduce the dose to 0.01%, then we will have to increase the concentration of benzalkonium chloride. And benzalkonium chloride on the long run, I mean, it is preferable to keep it at the lowest concentration possible. So now, since we don't have this issue of ocular hyperemia as it is the case with Lumigan, that's why the company kept bimatoprost at the dose of 0.03% in Ganford.
Okay, as someone who also sees quite a number of glaucoma patients, I agree with you, Dr. Marco, Dr. Jyoti. I see some patients who, even when we give a few months of Ganford, still the hyperemia persists. There are some who are more sensitive to PGAs than others. What are your opinions? Dr. Jyoti, you've not spoken today. Do you want to unmute and give your opinion? Dr. Jyoti, just unmute. Let's hear your voice.
Hello, that was a very nice talk, and we could get quite a number of comparisons. I feel there has to be some studies which should be done in the African population for us to understand the effect of Lumigan 0.01% versus Lumigan 0.03%. That would be my one of the suggestions that that will help the African countries to understand why. The other thing, the second point, I would say that benzalkonium chloride, the one which is a preservative, which is trying to reduce the concentration from 0.03 to 0.01, also causes hyperemia in some of the patients. They are reacting to that as well. So there are some of the patients who are reacting to that to 0.01, though most probably I have not done the percentage study that whether there are quite a number of not. But yes, Ganfort with a longer duration of use, yes, I have seen them frequently having the hyperemia. So I have not understood how timolol reduces quite understood that fact that how timolol reduces the hyperemia of 0.03% of bimatoprost in Ganfort. So that would be my thing, because most of the studies which have been done are done on the whites and not on the African population. And I feel when we do on African population, we might get some different picture of that. I don't know. Maybe I'm not right. I don't know, but we should do some.
Dr. Choti, I'm with you 100% because we have more allergies than the others. I find that we are more sensitive to the benzalkonium, and therefore it may not only be the concentration of the bimatoprost, but also the concentration of the presence or concentration of the BKA. Dr. Marco, do you have anything to add to that?
I don't have much to add. I think most of whatever I wanted to say has been said, but I know I have switched, I think all my patients from 0.3 to the 0.01%. And definitely there's a reduction in hyperemia in the ones that have been switched. So I'm happy with that, and patients are happier. But yeah, I've seen quite some hyperemia with Gunfort, and maybe Allergan in the long term can look into reducing the percentage of bimatoprost in the Gunfort as well. Yeah, thank you.
Thank you all very much. I don't want to take up too much of our time. Thank you everyone for staying for this long, much appreciated. We will in future keep time in terms of starting and stopping, and thank you everyone for participating. More notices will be posted on the notice board. Have a good night. Thank you everyone. See you next Friday. That's not this Friday, but next Friday will be a physical meeting. If you are able to be present, kindly RSVP to Evans. Have a good night.